Thank you, Sandra. Nick, I must say I have a tremendous respect. You have paved the way. You have demonstrated, just like now, sort of that you think outside the box and you have been one who has trained neurologists in the early time when nobody believed in neurologists. But and I'm not necessarily against the concept of training other specialties, but I'm going to outline why I disagree with what you said. What's the evidence? The evidence is that we have 9 by now with Resilient. We have 9 completed randomized trials. They were all positive. There's over 20,000 patients enrolled in these trials. And the vast majority of patients in these trials were treated by trained neurointerventionalists. The vast majority were cared for at stroke units, comprehensive stroke centers, or equivalent with vascular neurologists on site, and ICU, most of them neuro-ICU. The benefit of thrombectomy when performed by untrained general endovascular specialists such as cardiology or interventional radiology is unknown. And we know that procedural outcomes after thrombectomy are volume dependent at individual and center levels, and I doubt that cardiologists in those settings or interventional radiologists in those settings that you mentioned could achieve annual volumes that are adequate to maintain competence. So there's a few myths that I think we need to debunk, right? The myth number 1 is that there's a massive lack in interventional workforce, which is the main barrier in the performance of thrombectomy. So what's the estimated number of interventionalists? We don't know for sure, but it's going to be somewhere around 1,100 to 1,500 and growing. And what's the number of strokes? I was very excited and surprised, to be frank, to see Dilip's number, and he graciously shared them with me. Dilip Yavagal, who's obviously spearheading the MT 2020 project, to see these numbers that are sort of industry estimates of volumes. And in 2019, there's 60,000. It projected about 70, 80,000 for 2020. So it's continuously growing, despite the fact that seemingly we don't have enough interventionalists. So that comes out to about 40 to 50 cases per operator per year, which is approximately 4 cases per month, which is less than 1 case per week. That's kind of in the cardiology world. That's barely adequate to maintain competence, okay? So if you look at the total number of interventionalists and the total number of strokes that are being done, we have ways to go to be overburdened. And in fact, the barriers to thrombectomy access, they're clearly there, and I completely agree with you, Nick, that we need to do better. There's no question. We need to see those numbers even double from 2020. And I think we're going to get there. But the barriers are not lack of workforce. That's some of it, but it's a bigger picture there, and that has to do primarily with information and diagnostic access. People just don't know to call for help when they have a stroke as opposed to heart attack. So there's no availability of information about LVO and triage systems of care. And then, yes, there is physical access, which has to do with distance to facilities, availability of expertise, but there's other factors, devices, equipment, and we're getting there. It's getting better as the volumes are improving. And then there are, of course, financial access. So the issue of barriers to thrombectomy is not that simple. And the myth number 2 is that somehow magically in these rural areas that are densely populated with cardiologists who are going to fill the gap. The reality is that they have the same problem. They have a lot of cardiologists, but most of them are concentrated in urban areas. This is a paper showing that you're 8 times more likely to have an untimely access to percutaneous coronary intervention in STEMI if you live in a rural versus urban community. And the graph on the left-hand side shows that most people in rural areas have about 60 minutes or more access to cath labs when they have a STEMI. So they have the same problem. The same underserved areas that we have in stroke are underserved or less well served in cardiology as well. And then that's a paper that Jeff Saver was part of way back when in 2004, showing that, in fact, within a 65-mile radius, which is about an hour or 2 hours by ground or an hour by helicopter, 82% of the population had access to a neurointerventionalist within 3 hours of symptoms onset. Yes, there's a lot of underserved areas, but these underserved areas are also poorly populated. And that was 2004. We've done a lot of progress since. Not that we don't need more workforce. Clearly we do. But that the situation is not as desperate as it's being painted to be seen. Then the myth number 3 is that cardiologists are all waiting to busting at the seams to perform cardiology. Well, it turns out, look, my brother is an interventional cardiologist. I do cases in a cath lab. I talk to these guys all the time. They have zero interest in doing thrombectomy because I'll show you why. But first, we all know cardiologists. Nothing can stop them. If they were really interested in doing them, they would have done them by now. And this is statistics from performance of thrombectomy nationwide, showing that outside of radiology, neurosurgery, and neurology, i.e. cardiology and other specialties, the number of specialists performing thrombectomy is in the single digits. They just don't want to do it. And why they don't want to do it? You mentioned it, call. Call is equally burdensome for them. They don't want to be on call. And then the other thing is, look at the reimbursement rates for structural heart disease, the new procedures that they have, especially PFO, that we gladly feed them, and others, TAVR, all the stuff that is coming out now. Look at the RVUs compared to the RVUs for thrombectomy. Why wake up in the middle of the night to get a meager 9 RVUs when you can do an elective case and get 19 RVUs? They're not going to want to do it. And then myth number 4 is that cardiologists' catheter skills are adequate for performance of thrombectomy. Well, I think here, I think there is consensus among all neurointerventional societies, including neurosurgery, neuroradiology, neurology, you name it, that you gotta have especially the cognitive background to be able to do these procedures. You have to have done diagnostic angiography, and you have to have trained with neurointerventionalists. And this advantage of distance that we're talking about, okay, the neurointerventional center is an hour and a half away, and the cardiology center is half an hour away, therefore let's send the patient to the cardiologist. Well, if it takes the cardiologist an hour longer, which it does in untrained people, to open up the vessel, that distance advantage is gone. So I'm not convinced that even if they are closer and they are willing to do it, the outcomes are going to be better if there is a bit of longer waiting for reperfusion to occur in the hands of a neurointerventionalist. And, you know, they are the ones who emphasize the importance of cognitive skills. This is a competent statement on coronary artery interventional procedure from SCAI, and there's a whole slew of cognitive skills that you have to have in order to perform this procedure. How long does it take to acquire these skills? They are acknowledging that these skills are absolutely necessary. How long does it take to acquire them? Certainly not a weekend, certainly not a week, much longer than that. So in the end, you know, I think we should be careful what we wish for, because there's a short step from stent reaver to pipeline. And I don't want us to debate next year or in future years, about whether cardiologists should treat aneurysms with flow diverters or not. Thank you.
Great, thank you so much. We have time maybe for one question that we received from the audience, and then we're going to have a 15-minute question and answer session at the end. But one question for both of our speakers that we received by the app was if it's a team sport to be providing endovascular care, should neurologists be able to do STEMI and cardiac interventions to help meet the societal needs? And what do you all think about that?
Want me to try that?
Please.
I think it'd be great. Why not, if they really are interested? I mean, the point is that getting up in the middle of the night, nobody likes it, as Tudor said. But the point is, it has to be done. And the public health urgency is going to mandate it. If we don't fix this ourselves, one day the government's going to come along and fix it for us. So we've got to learn how to do this. If we did it together and shared the on-call burden with other interventionalists, it would make life a lot easier. Cardiologists, we did some training in Russia, and as you probably know, in Russia, it's not cardiologists per se, it's angiologists that do all the cardiac intervention, and they do intervention in the whole body. So their stroke numbers were, 4 years ago, in this whole city of Moscow, 20 million people, 40 patients underwent an intervention. And the numbers are going up dramatically every single year. And so I asked the guys, okay, I mean, you're really short of manpower to do stroke. Once you've learned how to do it, how long does it take you to train a skilled interventional cardiologist? The answer was 2 weeks. Now, I don't think that's necessarily true, but I don't think that cardiologists need to learn all the cognitive skills. They need to partner with you guys. Let you guys handle most of the cognitive stuff. All they need to know is if you say go, they go clean out the artery. And believe me, they are very skilled at doing that.
And Tudor, quick response.
Yeah. So, Nick, obviously it's not that simple. They are outlining, as I showed, that you have to have a certain cognitive skill set to do these procedures. And you never did procedures with somebody in your back telling you what to do. It doesn't make any sense. The one who does the procedure has to have the cognitive skills to deal with complications, indication, post-procedural care, and so on and so forth. But, you know, the question from the audience was great, but I just want to tell you something. It sounds all great and it all kumbaya, but I can tell you at my center, we have some length of stay issue with these implantable loop recorders. And we have an excellent relationship with cardiology. And I proposed, I said, how about we do them? You know, no big deal. You guys do all the follow-up and follow-up care and monitoring and whatever. But we implant them, you know, a small incision under the skin, no big deal. They said no. So they're never going to let us. It's all a one-way street. That's the problem.
They have to collaborate as much as we do.
Absolutely. So we'll continue that discussion at the end and go on to the next of the sessions.